Hello, my name's Nathan Filer. I'm an author. You can actually tell that I'm an author because I'm delivering this talk in front of a bookshelf. And at the start of the COVID-19 lockdown, all of the authors received a letter from 10 Downing Street informing us that it would be illegal if we presented any kind of public address without positioning ourselves in front of a bookshelf. I'm going to talk a little bit about my new book. Here it is. It's called "This Book Will Change Your Mind About Mental Health." I don't know that it will definitely change your. I've just realised how dirty my fingernails are because I've been using the barbecue. Embarrassing. I don't know that it will definitely change your mind about mental health, but it did change my mind about mental health as I researched and wrote it, and it forced me to examine my own practice from my time working as a mental health nurse, which I did for many years, and also to confront some complicated and at times uncomfortable truths. So I'd like to talk a little bit about that. Before I do, I'll read a short section from the opening of the book. Whenever I do sort of events and readings and things, I always read from the beginning of the book. I do that for two reasons. I do it because if you already have the book, maybe you already have it, and if you're already reading it, then if I read from the beginning, then I won't give away any spoilers or ruin it for you. And if you haven't, the other reason, if you haven't bought the book, but after this talk you are inspired to do so, then I will have saved you the tedious chore of having to read those first couple of pages, for which you are welcome. The opening chapter is called "The Language of Madness and the Beginning of Our Conversation." And this talk, I probably should have said at the beginning, this talk is called the Language of Madness because I would like to focus specifically. There's so much, when we talk about mental health, there are so many things we could talk about, but I'd like to focus a little bit on the choice of words, the language we use when discussing our mindsets, our mental health, our psychology. I remember the first time that I forcibly medicated a person against his will. It was 13 years ago, not long after I'd qualified as a mental health nurse, and I had started my career working on a psychiatric ward, providing assessment and treatment for adults in acute phases of serious mental illness. There was a patient, or service user, or client, or son, or brother, or friend, depending on whom you ask, who I'll call Amit. Amit had been refusing any medication for nearly 3 weeks, and with good reason. The medicine we were offering him contained a poison. It had been prescribed by a doctor who wished to harm him. In fact, this doctor, a consultant psychiatrist, had been struck off the medical register for his abuse of Amit during previous admissions, and so was now working illegally on the ward. Many of the nursing staff knew this and were in on it. During morning medication round, Amit stood in the doorway of the ward clinic, watching me closely. He watched the movement of my hand over the drugs trolley as I secretly replaced his regular tablets with harmful ones. He was wearing the same clothes that he'd slept in, and a pair of old trainers, one with a huge split down the side. Another patient, or colleague, or mother, or teacher, or daughter, had recently complained about Amit's smell. Whenever he sat in the TV lounge, she said, it made her feel physically sick. The problem was that Amit knew the water supply to his room was deliberately contaminated, and so he hadn't washed since he was admitted. I would try to talk to him about that again later, to find the right words, but for now, at least, The medication was the priority. I double-checked the dose on his chart, put 2 tablets into a clear plastic pot, and held it out for him to take. He stared at it. We both did. I tried to find some words of reassurance. I know you're finding it hard to trust us at the moment, Amit. I do understand that. We think that's all part of you being unwell again. He knew I was lying. I'll take them in my room, he said. I knew he was lying. You know it doesn't work that way. I'm sorry, but I need to see you take them. He cautiously reached out and took the pot from me. He prodded at the tablets inside. His fingers were stained dark yellow from tobacco. Nah, you're right, he said at last, placing the pot on top of the drugs trolley and backing out of the clinic, watching me the whole time. As he disappeared down the long corridor towards his bedroom, I wrote an R for refused in his medication chart. Why wouldn't he refuse? Of course he refused. If I were in his position, I know that I would. But I don't know if I would refuse with the same dignity he showed when later that afternoon the C&R team entered his bedroom. C&R, control and restraint. The legal, if controversial, techniques that mental health nurses are trained in to render a person unable to fight back. In subsequent years, this training would be rebranded as prevention and management of violence and aggression, which is reasonable if someone is smashing up the ward or threatening to hurt someone, but at times like this, for my money, the first description felt more honest. It had been decided in a team meeting that this was the last day Amit could refuse oral medication before we would use an injectable form. In the parlance of psychiatry, his mental state was deteriorating daily. He was well known to mental health services, and this was a typical presentation and pattern of his illness. If we could get him back on a stable dose of medication, he'd likely respond well. Amit was sitting on his bed, smoking and tuning through the static on a portable radio. He was talking to somebody that none of us could see. He looked up. There were 5 of us. Do I have to beg you? He asked. A colleague of mine explained his options such as they were, but that's the bit that stayed with me. Do I have to beg you? It's why I struggled to keep my hands from shaking as he was eventually held down on his bed and I administered the injection. He didn't put up a fight. We weren't preventing and managing violence and aggression. From Amit's perspective, I don't doubt that we were perpetrating it. In that moment, however good my intentions, I was knowingly participating in his suffering. It was around this time that I began to write a novel. I was living in a small shared flat in inner city Bristol, and between shifts on the ward, I would sit for long hours at my desk, or more often pace the floorboards in the hope that the physical movement of my body might somehow dislodge some inspiration from whatever stone in my brain it was hiding beneath. I was imagining the life of a young man who was suffering from the symptoms of a strange and commonly misunderstood illness, or disease, or condition, or trauma, or phenomenon, or curse, or gift, depending on who you ask, and the lives of this man's family and friends. This was a work of fiction, but it was fiction that drew upon my very real feelings about working in mental health care, as well as many of my personal childhood experiences. I reckon that's where imagination comes from. Whether consciously or unconsciously, we dig up memories of our experiences, what we've seen and done and read and felt and hoped and fucked up and desired and regretted and all the rest of it, and then we reshape them a bit here, a bit there, until they resemble something entirely new. For the protagonist in my novel, though, experience and imagination had become inseparably tangled so that he no longer knew what was real and what was happening only inside his head. For me, understanding and responding to what this character was going through was principally an imaginative exercise, or put another way, an act of empathy. This is something that writing a novel and reading one, and mental health care have in common. To do each of them well requires bucket loads of empathy, of striving to understand and share the feelings of other people. Of course, as an author of fiction, I was also responsible for creating the very problems that I then had to empathise with. Though, thinking about Amit, I probably did that as a nurse quite often too. So my protagonist was having a hard time. I decided not to diagnose him in the novel, but if I had, I'd have probably landed on schizophrenia. So that's the opening of the book. I finished writing the novel, incidentally, that I referred to in that section. It was called The Shock of the Fall. There it is, like that. It took me quite a long time to write it, many years. In fact, there's a great Peter Cook quote that pretty much sums up my experience of writing that first novel. It goes, I met a man at a party. He said, I'm writing my first novel. I said, oh really? Neither am I. But I did write it. And it was the book that eventually led to me writing this work of non-fiction. Because people read my fictional account of a young man living with schizophrenia, and a number of those readers were generous enough to reach out to me and to share their stories, true stories, about living in the shadow of that diagnosis. And some of those stories sit right at the centre of this new book. And it was clear from the stories I was being told and from my subsequent research that schizophrenia, and not just schizophrenia, but indeed the whole notion of mental illness means different things to different people. You can probably tell that I am reading some of this talk from notes. I've got to do that. I haven't learned it. There's credible and often fiercely acrimonious debate across and within the fields of psychiatry, psychology, neuroscience, genetics, and various mental health charities and organisations over everything, from causes and risk factors to categorisation and diagnosis, right through to treatments. There is no consensus on anything, and the stakes are high. Because, yes, we are talking about ideologies and professional rivalries and often politics, but crucially, we are also talking about people's lives. I don't approach my writing as a mental health professional, although of course that will exert its influence, but I approach it as a writer, which means that my main job is to find the right words. And the first thing that became apparent to me when researching this book is that there is no uncontroversial language when talking about mental illness, and that includes the phrase mental illness. On the whole, the controversy of a term relates to how medical it feels. So let's consider a word that at first glance may seem fairly innocuous. The collective noun for people accessing treatment. If you are a user of mental health services, and if you believe that your distressing thoughts, feelings and behaviours are an illness, presumably an illness located within your brain, but otherwise exactly the same as a physical illness, then you might prefer to think of yourself as a patient. After all, if you're the same as those patients receiving care for diabetes and cancer and heart disease or whatever, then why would you want to be called something different? However, if you are of the view that even your most alarming and distressing and uncharacteristic thoughts, feelings, and behaviours are not symptomatic of illness so much as perhaps a natural response to undischarged trauma, to grief, to unbearably painful life events, then to see that wrapped up in a medical language that inevitably begins with you being declared a patient might feel seriously problematic. And it was during my own training as a mental health nurse in the early 2000s that the term patient fell out of favour, replaced with service user, which was considered to be the more neutral term. But then what about people like Amit? People who are detained in hospital and medicated against their will. Does the term service user really cut it for them? Can we, in all conscience, say they are using our services? Probably not. Today, a growing number of people are eschewing both terms and self-identifying as survivors. Meanwhile, the council in the UK, the Council of the Royal College of Psychiatrists recently recommitted to patient. And if all this sounds sort of fraught and political, and if it all seems like a debate about language, like a semantic argument, that's because it is. But in the world of mental health care, language is everything. A truth not widely appreciated is that the overwhelming majority of what we confidently call the mental illnesses are not arrived at by looking at a blood test or a brain scan or any objective physical test of the kind routinely used to confirm diagnoses in other branches of medicine. They can't be, because such tests do not exist. Rather, it is the words people say or do not say, as interpreted by mental health professionals, that as much as anything else will determine a diagnosis. And that language of diagnosis, for better or worse, has the power to radically alter people's lives. On that note, I'm just going to put the lights on. Now, this doesn't mean that psychiatric diagnoses, and I don't know whether it was clear, but I went up to put the lights on, and then I sat back down, and then I realised that I was going to have to sort of use some software in order to edit two parts of, like, the first part of the talk before I got up to put the lights on, and then this part of the talk after I put the lights on, and I realised I don't actually know how to use any editing software. So if you're still listening to this talk, it means that I worked it out, and good. Now, this doesn't mean that psychiatric diagnoses are arrived at completely arbitrarily. They're not. Rather, they are the names ascribed to human experiences that have been observed to frequently group together. So we can open the window. It's so hot. Do you know, I've given talks before. I've given a version of this talk before. It feels so strange to just do it at a computer rather than to see people in an audience. So, I hope that you're finding it interesting and that you're doing okay. Let's diagnose someone together. I'm gonna imagine that you are here in the room with me, in my study, and we will together now arrive at a diagnosis. So pay attention. a young child in the classroom who has difficulty paying attention to what the teacher is saying. She might also be easily distracted. She has difficulty waiting her turn, so she interrupts. She fidgets in her seat. And this pattern, in this case of behaviours, remember thoughts, feelings and behaviours. In this case of behaviours, this pattern is seen often enough that there emerges the medical illness of, and I wonder if you said ADHD. And so it goes for virtually every other diagnosis. A terrified adolescent who's hearing voices might also have unusual beliefs. He thinks his neighbours are inserting thoughts into his head. He thinks that MI5 are tracking him, and his parents say that he has withdrawn socially. Such a story is seen often enough that there emerges a pattern, a notion, an idea, and we call this idea schizophrenia. A problem with this way of diagnosing is that human experiences don't like to be placed in boxes. They have very blurred edges. So a person experiencing many of the typical thoughts associated with a diagnosis of schizophrenia might also be experiencing many of the feelings associated with a diagnosis of bipolar. Traditional psychiatry's answer to this, certainly since the 1980s, has been to create, and we'll get into what was important about this period in a moment, but traditional psychiatry's answer since the 80s has been to create more and more and more boxes. Something looks a little bit like schizophrenia and a bit like bipolar, et voila, that's schizoaffective disorder. Or if you're exhibiting a quality of suffering that doesn't quite reach existing diagnosis in intensity, well, that's okay. You're allowed to have a medically sounding illness as well. Not quite depressed, that's dysthymia. Not quite bipolar, that's cyclothymia. To quote the critics of this diagnostic method, there is a disorder for everyone. The rapid proliferation in the number of psychiatric disorders that you or I might be found to be suffering from has, as I said, mostly occurred in the decades since 1980, during which time we've gone from 120 odd named mental health disorders to 541, and this is where things turn political. Many academics suggest that it's no coincidence that this increased medicalisation of distress began under Thatcher in the UK, under Reagan in the US, with the rise of a global neoliberal agenda that began redefining citizens as consumers and poverty as the fault of the poor. Poverty as the fault of the poor. It's beyond the scope of this talk to go too much into the causes of mental illness, though I certainly do that in the book. I'll say for now that I believe that our genes and our brains and our biology play a really important part in that. But so too does our environment. We know, for instance, that poverty and inequality have a catastrophic impact on our mental well-being. I've given a version of this talk before. I've actually given a version of this talk in Sydney, Australia, back a few months ago. It feels like another world when you could get on an aeroplane and do that. And so I looked into the widely acknowledged higher rates of suicide among the Aboriginal population. And the reasons for that are going to be many and complex, but among them will almost certainly be income inequality. In his book, The Health Gap, Michael Marmot. Suddenly thinking whether I've got it. I think I do. Boom, 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 boom. Very good book. In his book, The Health Gap, Michael Marmot highlights that Australia ranks second in the world on the United Nations Human Development Index, which combines life expectancy, education, literacy, and national income. Second in the world out of 187 countries measured, just topped by Norway. It's always the Scandinavians, isn't it? Those bloody Norwegians. Am I right? I just tried to do an Australian accent. I mean, it's too. I can't edit this again. We're just gonna. I'm sorry, and we're just gonna have to press forwards. Second in the world out of 187 countries measured. And yet, if Australian Aborigines were considered to be a separate nation, they would rank 122nd in the world. How do these social and political issues get entangled with psychiatric diagnostics? Well, the proliferation of the so-called mental illnesses may, at least to some degree, I suggest, serve the interests of those in positions of political power. Better it be understood, or more convenient for some, that it be understood that a young millennial who is falling apart while struggling to pay 2/3 of their rent from their increasingly precarious 0 hours salary to rent a small room in a shared flat, better that they are suffering from a panic disorder, something that we can conceptualise as being tucked away neatly inside their brain, than to countenance the possibility that the real sickness may lie elsewhere. Today, psychiatric diagnoses can feel not entirely dissimilar to brands, with the currently more popular brands, such as depression and anxiety, getting marketed and monetised to a far greater extent, resulting in the publication of huge numbers of self-help books and the development of new therapies, whereas the less marketable brands, such as schizophrenia and such as the so-called personality disorders, suffer from a diminished investment. And so yet another inequality is forged. And I just feel I should clarify there that when I talk about depression and anxiety as being popular, I obviously don't mean they're popular to experience. All of these things are horrible to experience. I simply mean that more public empathy and more resources go their way. In arriving at a psychiatric diagnosis, it can be difficult for clinicians to know where to draw the line between what is normal and what is abnormal. If we return to ADHD, for instance, even highly skilled clinicians often come to different conclusions about what constitutes a child's appropriate level of attention. In my book, I quote the consultant child and adolescent psychiatrist Sami Tamimi. He says this: when a clinician claims that a patient is clinically depressed or has ADHD or has bipolar or whatever, not only is he trying to turn something based on subjective opinion into something that appears scientific, but he is also reifying the event that's turning something subjective into something concrete. This causes a kind of tunnel vision where the psychiatric diagnostic version of events becomes the dominant story and alternative ways of viewing are pushed to one side. Hence, if someone believes ADHD is a real disorder that exists in the brain and is potentially lifelong, that person, and those who know them, may come to act according to this belief. This is to create a pessimistic, self-fulfilling prophecy. Interestingly, it was during the 1990s that there was an epidemic of the ADHD diagnosis, especially in the United States. And by 2013, a staggering 11% of school-age children in the States were given that label, with vast numbers of them prescribed obscenely profitable medication. We now know that the youngest child in a classroom is more than twice as likely to be diagnosed with ADHD than the oldest child in the classroom. Now, does that mean that the youngest child is more than twice as likely to have some sort of brain abnormality? Of course it doesn't. Does that mean that the youngest child is going to find it harder to sit still and pay attention because they are 4 years of age instead of 5 years of age? Yes. We have turned immaturity into a disease. Now, of course, there will be children who have more serious developmental delay, and there will be children, of course there will, whose brains are not functioning normally. These things exist on a spectrum, but a lot of what passes for ADHD may be nothing more than normal developmental difference. We are supposed to be different. So there are problems with mental health diagnoses, but here we must be careful, because however shaky the foundations of these labels, however shaky, I beg your pardon, the scientific foundations of these labels, people's pain, people's suffering, people's experiences, they are real. In my book, This Book Will Change Your Mind About Mental Health, I tell the story of a woman named Claire who talked with me about her son, Joe. Joe's behaviour was extremely challenging, often criminal, on one occasion violent, which I believe came from a place of fear and confusion. He drank heavily. He was massively overweight, a result of the side effects of antipsychotic medication that he took. And Joe died alone in his flat at the age of just 19. In the years before his death, Joe was diagnosed with hebephrenic schizophrenia, a subtype of schizophrenia characterised less by hallucinations and delusions and more by social withdrawal, irresponsible behaviour and unusual emotional responses. When Joe received this diagnosis, Claire, his mother, at least for a short while, told me that she took great comfort from it. It helped her. It helped her to make sense of what was going on for her son and to feel less alone and less afraid. However, since Joe's death, hebephrenic schizophrenia has technically ceased to exist. It never made the cut for the latest edition of the official diagnostic manuals, along with paranoid schizophrenia, incidentally. So paranoid schizophrenia still very much exists in, I guess, public imagination, and will continue to do so, I'm sure, in films and books for years into the future, but it's not technically, officially a mental health disorder anymore. In psychiatry, in all medical disciplines, truths change over time. Meanwhile, Joe remains dead, and Claire continues to live every day with that concrete, absolute, and unalterable fact. And it is these truths, the truths of people's experiences, rather than abstract debates around diagnosis and labelling and so on, that we must never allow ourselves to lose sight of. Before I finish, I'd like to say a quick word about anti-stigma campaigns. It's impossible to talk about mental health without talking about stigma. In some ways, stigma's come to dominate much of the discourse, especially, I notice, via social media. So we talk and we tweet and we post messages about mental health stigma and the problem with stigma and the need to reduce stigma. And it's all very well-meaning. It's often spearheaded by celebrities, even royalty. It absolutely broadens the conversation, which is fantastic. It does also possibly have us looking in entirely the wrong direction. The standard anti-stigma campaign equates mental illness with physical ailment. You wouldn't tell me to pull myself together if I had diabetes, a broken leg, etc. And in truth, we know that things are much more complicated than that, and this relates to some of those social determinants of mental ill health. So I've already talked a little bit about the role of poverty. There are also many other social causes: racism, bullying, adverse childhood experiences, including physical, sexual, and emotional abuse, and so on. And so that well-meaning anti-stigma message risks individualising what are often, not always, but often issues of prejudice, discrimination, and abuse. The psychologists Anne Cook and Dave Harper make the eloquent point that we don't talk about the stigma of being a woman or the stigma of being black. We talk quite rightly about sexism and racism. Arguably, we need to be doing the same where our mental health is concerned. Either way, the picture is complicated and perhaps cannot be adequately communicated with a simple soundbite. We broadened the conversation, now we must deepen it. So I'll draw this talk to a close by reiterating that certainly there is no uncontroversial language when talking about mental illness, and that's because there are no uncontroversial ideas. Everything is up for grabs. We haven't even got into the contested area of treatment. I'll save that for another talk, perhaps. But we mustn't get to a point where this controversy dissuades us from interrogating ideas, listening to the ideas that we don't agree with, and being prepared to reflect upon these and change our own position. I had to do a lot of that when writing this book. I'll show you it again. That's it. In case you want to read it. I had to do a lot of that, a lot of changing my own thinking and my own position on this subject. And but I believe that it's through that openness that we can begin to find clarity. There is a fragility to the mental health of everyone, and so it serves us all to be a part of this conversation. So on that note, thank you very much for listening to this. If you made it all the way to the end, stay safe. Hopefully see you on... I mean, I really should have planned a fucking ending for this, shouldn't I? Have you got to the end anyway? Are you here? Are you still there? I mean, maybe you sort of skipped ahead and you're just listening to this bit now.